Hi, I'm Lucy Davis.
And I'm Hasan here.
And this is Room for Improvement, the podcast dedicated to service improvement in axial spa care. Today, we're delighted to be joined by a colleague from Royal Berkshire, who's going to talk to us about their work within measurement for improvement and particularly around their mental health work. And before we get into that, we're delighted to be joined by Mark, who is a patient with Axial Spa, who's really going to talk to us about his experience with anxiety and depression, both pre and post-diagnosis. And we know that a significant proportion of patients with Axial Spa do experience both anxiety and depression. And really, this story does bring to life just how important it is that we focus on this.
Mentally wise, doctor to doctor to doctor. Loads of tests run on my body over 18 months, and I really did struggle mentally throughout that time because I couldn't understand what was happening to me. I got very, very thin. I couldn't move. I couldn't get out of a chair. I could barely shuffle around, and the mental impact was huge, leading to, I have to say, some suicidal thoughts, as in, well, if I'm 33 or 34 years of age, as it took about 18 months to be diagnosed properly with AS. If this is the rest of my life, then perhaps it's not worth living. And that was a very, very dark time. It was one of the worst moment of my life, to be honest. And losing your health at a young age like that was quite a shock. And as I say, nobody could diagnose me. No one could tell me what it was. I saw so many doctors. They were all doing their best, but none of them had enough information about ankylosing spondylitis in order to be able to help me. It was only one GP who I saw after 18 months of agony who looked at me and said, I'm surprised you've lasted this long. She sent me for an emergency appointment at the UCL. I saw a rheumatologist for the first time in that 18 months. He diagnosed me in minutes.
So what a interesting story. I just think mental health is a really big issue in our patients, in most of our rheumatological patients, and possibly we're not great as rheumatologists at addressing it. What would be really interesting to do is listen to our host who will talk a bit more about this. So without further ado, I'd like to introduce Dr Antoni Chan, who's a rheumatologist a lot of you would know well. He's from Royal Berkshire Hospital. Welcome, Toni.
Thank you very much, and thank you for having me on the podcast.
So, Toni, we've just listened to Mark's story, and I understand that you have addressed mental health as part of the problem that you've encountered in your ankylosing spondylitis or axial spondyloarthritis clinics. Do you want to just tell us a bit more about why you chose that particular aspect or patient-related outcome issue in your project?
It is for stories like Mark, which is a very brave story that he shared with us today. It is for patients like him and many others with axial spondyloarthritis who suffer from issues of anxiety and depression. And we know that up to a third of patients with axial spondyloarthritis may have anxiety and depression. It is something that we probably under-detect and under-diagnose because a lot of our focus obviously is on objective outcomes. We want to see an improvement, for example, their blood tests or their scans. And some of these other things, due to the pressure of time, sometimes does not get addressed adequately. And yet these are the very things that can affect the patient well-being, their outcome, and how they actually perceive things going forward in the long term.
But what made you choose mental health, though? In rheumatology, there's a big talks of patient-related outcomes, and a lot of us are focused on, say, fatigue, for example. But I'm just really interested that you picked on mental health.
It is the experience that in the clinic, seeing many patients who describe to me some of their struggles with anxiety and depression, and also how we can be thinking of ways to trying to address it. And so when we got into the Aspiring to Excellence program, we thought that this would be an excellent opportunity to have a good look at this using some of the quality improvement techniques that we have, but trying to address something that we know that is very prevalent in our service, but not measured. We don't have any data on this. It's something we see, but yet we don't have really any handle on this. And so 2 years ago, we decided that this would be a good place to, if we were to do one thing, this would be a good one to do because of the possible benefit to our patients in the long term.
So you mentioned data you did. So I think data is probably the key here, isn't it? So can you just go about what sort of data you collected and to identify firstly the problem?
So we sat down as a team. We had a discussion as to what we would like to collect. It's very important to understand what we are measuring in terms of data. There's a lot of data you can collect, but it only collect the data that is going to be clinically relevant to the intervention that you are trying to do. And so we also did a literature review on what available scores there are that would be useful. And we had a look and we had a discussion. We also had some patients in clinic who we tried some of these scores in the clinic. And we finally came up with the Hospital Anxiety and Depression Score, the HAD score, which is a validated score using clinical practice to help measure both elements of anxiety and depression. And so we felt that if we could measure this in a group of our patients, we would start to have a baseline and start to understand what the actual prevalence of depression is in our axial spondyloarthritis clinic.
Okay, so I mean, you've chosen the HAD score. So I just want to be, can we go down to more of a practical level? Mm-hmm. For us busy clinicians, busy clinics, how did you go about it? Was it like, can you just talk to us a bit more about, was it paper copy? Did you use digital platforms? Would you like to share with the listeners and how you went about doing that?
So it's really important, first of all, to engage with the patient. So in order for the patients to complete this, there is a need to actually explain to them why you are doing this and what the whole process involves. So in the first visit, it was a paper form because the patient was in the room and we explained to them, and a lot of them, immediately said, yes, anxiety and depression is something that, that they may have come across and known people who have it. So the more we can talk about mental health, I think the better it is, and we shouldn't shy away from doing that. But what is important is then to have the patient's engagement. And so we gave them a paper form, which they completed. Now, it takes less than 2 minutes to do. So in the busy clinic, we have timed this as well, and it doesn't take too long to do. And the patients can complete it after the clinic. So before they go home, they're in the waiting room, they can do that, or in the clinic itself, if you want to spend more time trying to explain to the patient how to actually complete the score. Once they've done that, we then can move on to an electronic system where we don't have the patient physically having to come back to complete the score. So we will send them a text message to complete the score on a subsequent time interval that we have decided, that is 3 or 6 months' time. If they don't have access to IT, a smartphone or computer, then we will send them a paper copy with a return envelope so that they can also complete the score. So at the first visit, we tell them that we are doing a baseline, and then we are going to put in an intervention if there is a need for that. Clearly, if they don't have anxiety and depression, then we wouldn't necessarily need an intervention at that stage. And then to measure again, the more you can measure, the more you're able to understand, firstly, the prevalence of the issue, and secondly, the effectiveness of the intervention that you're trying to put in. And I'll come to the intervention that we did in the next part of the discussion.
Yeah, I just want to ask from the practicality point of view again. So did you find that your capturing of data was better when you did it in clinic, when the patient was there in front of you and before they left, versus, when you sent them messages? Was there any difference in that?
So I think this is where we found that the patient engagement was very useful. If we had the patient who was in clinic today and we explained to them the importance of doing these scores and they understand why, what they're going to gain from this, then we found that the completion rate was 100% on the subsequent digital interactions. If we just send them a digital score without the full explanation, we are getting only about 60 to 70% completion rate because people don't fully understand what the need to do this or what the outcome is. So if possible, at the first visit, it's the opportunity for education, for training and understanding that improves your outcome in the long term.
So I think, Toni, one of the things that I know I love about yourself and the Berkshire team as a whole is that really calm, methodical approach that you take to making changes simple and trying to break them down and having the patient at the centre of that. So I guess I'm really interested in trying to now follow that journey through. So we've got the baseline score and we've ensured that patients no, actually there's a benefit to doing this, and then we're engaged in continuing that going forward. What did you guys do next? What was your next step?
So we engaged with our clinical psychologists, having had the baseline measurements. We understood that there was a significant proportion, between 20 to 30% of patients had an element of anxiety and depression. So we got our clinical psychologists to come along, and we were then designing the intervention. And the feeling at the time is that we would do some either one-to-one or group therapy sessions addressing anxiety and depression. And then March 2020 came, and then COVID appeared. And then we thought we had to kind of regroup and try to deliver this in a different way if we can't see them face to face. And this is when we developed the video. We decided that what we could do is we could get them to have the same message, same information as if they were in the room, but through a video link. And then upon watching that, they could have a few options, a resource. They were signposted to different ways of trying to address some of their needs, and then remeasure again with the HAT score again at intervals after the intervention was made.
Can I ask you? That's really interesting. Obviously, you used COVID-19 as an excuse to use digital platforms. How easy? I mean, just again, I'm going to a practical level in an NHS environment. How was it? How easy was it, or how difficult was it to actually develop the video?
Yeah. So thank you. So the challenge with COVID, it turned out to be an opportunity, because post-COVID, it turns out that the video is very much something that the patients like very much. It's a very personal thing. If they can watch it in the comfort of their security of their home, rather than to come to some group session, if they may not be ready yet, it's an option. I mean, obviously going forward, we've restarted the group educational sessions again, but they still have the hybrid. They can still do the video. To the second question, how easy is it to organize? I think we had the engagement with the clinical psychologist in terms of the content was important, to ensure that the content is really relevant and clinically sound for our patients. And then we can do this in-house. So we use our medical photography or medical illustration department, because we found out that they were doing a lot of videos on patient consent. They were doing videos on people who are going for operations, and before they turn up on the day of the surgery, they had people explaining to them what the actual procedure is, and that helps smooth out the consent process. So we asked them whether they could do this, and the answer is yes. And so they came up to our department for an afternoon. We had our clinical psychologists, and we had our physiotherapists, and we went through the whole content of what we would have delivered in a face-to-face session, but now on video.
No, very, very, very interesting. And a cheeky question: does it carry a cost?
No cost, because the medical photography people are already in the department, and they were doing these videos for other departments as well. So for us, it was a trust initiative, and our trust has been very supportive of our engagement in the A2E program. So we see this as trying to improve our sort of patient experience and our patient pathway. Because it's freely available, it's on the YouTube channel, which the link will be shared with you. It's accessible to any NHS trust. So we feel that this is not just for us. Anybody who feels that they may want to use this, you're very welcome to also use it. So if we can help in any way to help address some of these issues of anxiety and depression in our XPAR patients, then we think that would help in the long term.
So you've done the video, and obviously we've done the data collection initially. I believe you went into some more data collection after the video.
Correct. So we did. So we did a data collection after the video. So we sent them a message, having done the completion of the scores, because at the time we couldn't see them face to face. So we asked them to view the video, and once they viewed the video, we would then send them scores on a regular basis to ensure that the scores were improving, or if they were not, whether they needed other types of intervention. And what we found, there was a significant drop in their HAT score. So when we first started, quite a significant, more than 50% of people were scoring high on the HAT scores. And over time, that number halved by the intervention that we put in, which is the video. Now, the video, it's not the end all. So the video then leads you to resources like talking therapies, phone access, or whether you need to go and see your GP, or whether you need to have, a referral to anxiety and depression services.
So, I mean, is this actually translatable, do you think, in our other areas of our rheumatology practice?
I think so. I think anxiety and depression is not just in axial spondyloarthritis. We know very high in even the other conditions, psoriatic arthritis, for example. And so I think these can be placed into other scenarios as well. So it is applicable across MSK, but I think it's also applicable across many other disease areas as well. And I think this is one way where we can start to address some of the issues with mental health. It will be a start anyway. It wouldn't be necessarily the all-encompassing solution that we need, but it will be a start of that conversation with the patient and opening up and trying then to address some of these more hidden symptoms that the patients have.
So I know, Toni, when you started this piece of work, this was around using it as a PDSA cycle. So you were testing this in its implementation and seeing whether it worked or not. And then quite clearly, as you've just described there, that the data starts to show that it's having a real benefit. So could you tell us a little bit more about how you've gone about embedding that and how it's become sustainable within your service in a post-pandemic world?
Thanks very much. So we planned it, and then we sort of did the study, the intervention we studied, and then we have reviewed the whole process after 1 year, and certainly there were more than 50% of the patients had dropped from a high score to a moderate, and another 50% from a moderate to mild score. So we knew that it was making inroads into their anxiety and depression. But we also wanted to know the people who didn't respond. So that's the next part of the PDSA cycle is to contact those patients and to see how come the scores didn't change as much. It might mean that they would need a different level of intervention beyond the video. And so the next PDSA cycle is to have that face-to-face sessions that we are now reestablishing again, and to have more input to keep driving that improvement cycle. So we're going around in sort of the second and third wave now to try to bring down the scores from those people who are still scoring high.
Yeah, and I think makes my improvement heart very happy, because you guys are absolutely driving through that continuous improvement ethos in your work, that actually we've made real inroads here, but there's still much more for us to go out. So let's keep thinking that through. And I'm just interested in how you sort of structure the thinking as a team around that. Are there any other sort of tools or methodologies you've been using to try and plan out or map out the interventions and tests of change of planning?
Yeah, so we had regular team meetings before we implemented this, and we also used this as a teaching or learning opportunity for our team. So we did pre and post scores on them as well, not depression scores, but learning scores. So on asking them what is their understanding of mental health issues, how would they approach it? Is that something they feel confident about discussing with patients in clinic? And so the scores were showing that they were most times not as confident. And then we brought in our clinical psychologists to do sessions with them right at the beginning, in terms of trying to find ways to explain to our patients, signpost them to resource. And then we did another cycle of learning again. And over a year, we have seen an improvement in the confidence of our team in trying to discuss mental health issues, not worrying that they might be opening a can of worms here, but rather trying to kind of, that our role is not necessarily the person who does the therapy. Our role is to address it, to detect it, to articulate it, and then to signpost to the people who actually know how to do these things. And if we can do that, hopefully we can make lives better for a patient, for example, like Mark, who spent a long time before, some of these were addressed.
I mean, I think that's really fascinating what you've just said there, because I think one of the fears as clinicians that we have is that if we start delving into mental health, we're going to open a can of worms. But as you say, that's not our role. Our role is to identify the issue and then ideally signpost people, because there are other people who can help. And I think that's fascinating how your department has actually done that. And I think there's a lot of learning to be done by others from the work that you have done here. So well done. I
think collaboration is key here. So we know that we have a lot of very skilled health professionals and colleagues around in the hospital and other places. And if we can somewhat identify the people who are best seen by the right people, then I think hopefully we can improve the patient pathway. If we can get people who are best at doing something, seeing the right people in their clinic, then hopefully we can get to a better outcome.
No, that's great. That's great. We're coming to the end of the podcast. What I'd like to ask you is, what advice would you give, our colleagues or our peers who are considering a service improvement project in their department?
My message would be, firstly, do it, because you will find you'll enjoy it. So start with small steps. You're not going to solve everything immediately, but if you start it with small steps, you are very likely to be in a much better place in a year's time. And so do small steps and think and work carefully with your team, and try to do, if you have anything, just try to do one thing this year, and you will find yourself in a better place. So one thing, it could be measuring the HAT score on your patients, and do that. And in a year's time, you'll be having data that you can start to analyze. Secondly, is only measure data that is useful. There's a lot of data, there's a lot of noise. I work on a very simple principle of rubbish in, rubbish out. If you put in rubbish, you get rubbish. So make sure you know what you're actually measuring, and be very clear about what your objectives are. What are you trying to achieve? Because sometimes if we don't spend enough time doing that, we find ourselves spending a lot of time collecting data with no clear objective. What are we trying to achieve? We are not in a sort of a data warehouse business here. We are here to treat our patients. And if we can find the data that is going to impact and change their life, then that's a great thing. And thirdly is collaboration. So there are people in your hospital who will help you with data. There are informatics, there are IT people, there are quality improvement teams, medical illustration in our situation. There are people around who will help you if you engage with them. So we haven't had to travel very far. In fact, prior to the Aspiring to Excellence, we identified these people, but now we have a structure along, of how to go about to do these things.
Fascinating. Thank you so much, Toni. That's really great. So in summary, you're saying any changes that you want to make, break them down into small chunks, collect the right data, which I completely agree with you, and have clear objectives as well. And 100% agree, collaboration is probably the key. So thank you so much, Toni. That's been, really, really interesting talking to you, and you sharing, your experiences. Thank you so much.
A pleasure. Thank you for having me on the podcast.
Fab, thanks, Toni. And if you want to, you can learn some more about the Royal Berkshire Project by reading Driving Improvements in Axial Spa Services, Building Strong Foundations Through Aspiring to Excellence, which is the first learning report to come from the Aspiring to Excellence programme. And also throughout this podcast, we've discussed measurement for improvement and PDSA cycles. And if you want to learn a little bit more about those techniques and scrub up on some of your service improvement methodology, please do visit nas.co.uk/room for improvement, where you can find a selection of videos and resources that will be able to help you.
This is a CPD accredited episode. To collect your certificate, please email aspiringtoexcellence@nas.co.uk and quote the code Antoni. Room for Improvement is brought to you by the Aspiring to Excellence programme from NAS, which is sponsored by AbbVie, Biogen, Lilly, Novartis and UCB, and in partnership with BritSpa and the NHS Transformation Unit.